Welcome guys to this another video discussion on Harrison based MCQ. These videos are designed in such a fashion that completion of MCQ will lead to completion of chapter. Now today's topic is Whipple's disease from Harrison. Now before going into discussion, let's just talk about one of the course that we are going on currently. It is Harrison revision series, in which our plan is to complete Harrison within 6 month duration. So we are going to follow this schedule starting from the 12th of May until till this December. Our target is to complete Harrison within 6 months in the form of test and discussion. There are a lot of queries I have received till now from all of you. One, whether how it will be done. It is obviously test and discussion, batch-wise discussion. Discussion can be for some of the based video modules, some of the based by direct discussion of the topic. Then who are making question? No, I am not sole person who is making the question. There are a lot of people in the group who are part of it. Our plan is to complete Harrison within 6 months stipulated time, and it is mainly for target of NEET SS, which is in December. Also for the residents who want to complete Harrison within 6 month period of time. And also it will be useful, I guess, for the final year MBBS student. Okay. To join this course, link is available in the description. You can click on the link and join there. And secondly, those who want to join the WhatsApp discussion, the free discussion for the Harrison based MCQ, also the link is available. You can also join the WhatsApp group too. Okay. So coming to this topic of Whipple's disease. So first question for today is a 52-year-old man presenting with chronic diarrhea, weight loss, migratory arthalgia, low-grade fever for 4 years. So this is a chronic disease. Duodenal biopsy shows foamy macrophage containing pus positive inclusion. So this is nothing but give an answer for it. It is the only single one-liner that you need to know at this point regarding this disease. It is nothing but Whipple's disease. Okay, so it is pus positive inclusion duodenal biopsy which will reveal. Now, coming to the topic of this Whipple's disease, that thing you should know regarding the notes of it. So, this note is completely from Harrison. Harrison these notes. Now, you can see Whipple's is a chronic multi-system infection caused by Treponema whipplei. It was first described in 1907, so 100 years back. It was the first described disease. And issue with the disease is it's very rare, but often misdiagnosed, so which make it much more rare. This has lot of good complication like CVS and CNS complication, which may lead to fatal complication if not treated well. Okay, so it is caused by, as the name goes, Treponema whipplei, which is gram-positive bacilli. Issue with Treponema whipplei, this gram-positive bacilli, is that it is very slow growing time. So doubling time is 18 days. So it is very difficult to culture. Okay, so culture is not the best test for diagnosing the case. You need to rely on other methods like PCR for diagnosing these cases. Okay, and also other alternate methods like duodenal biopsy, which will reveal pus positive macrophages, foamy macrophages, which will give a clue that this can be Treponema whipplei. Now, it has got multiple genotype, but a single phenotype. Single phenotype is that similar clinical disease, similar clinical pattern is seen. Now, with advent of diagnostic tool and advent of knowledge of the disease, prevalence has been on rise, not because for other cause, because we are detecting this thing very early. So prevalence is more, around 10 million currently. Even prevalence is very quickly identified in other countries than in India, and it is very common in rural Africa, where infectious diseases are more common. Now, most important point here, you remember that less than 0.1% exposed develop the disease. That means any culture, anything coming out positive doesn't mean any culture, or say PCR coming out to be positive doesn't mean there is Whipple's disease. It can be purely, purely, purely due. They can be carriers, carrier or asymptomatic carrier of the disease. Okay. Why carrier? Because they can transmit to other people. So in immunocompromised, it can present and disease. So transmission is by fecal route or oral route. Okay. There is possible droplet infection that has been discussed but not proven currently. Risk factor is that male are more affected than female. Age, with increasing age, risk factor increases. Sewage exposure increases the risk. So idea is that male are more commonly affected than female in case of Whipple's disease. Okay. Now, coming to the pathogenesis, few important point I need to tell you here at this point. So, main pathogenesis is that cell-mediated immunity is affected. Cell-mediated immunity affected. That's why there is decrease in response of Th1 and increase in T regulatory cell, and which lead to impaired phagosome and lysosome fusion, resulting into disease processing. Now, here what you look as cell-mediated immunity is on decline. Cell-mediated immunity is on decline. So what will happen if you give steroid? It will further decrease the immunity. So steroid or anti-TNF alpha will make the disease bad, very, very bad, and make the prognosis bad in such cases. Okay, all right. Now, obviously, pathology hallmark is pass positive forming macrophage, which is diastase resistance. Now, coming to the next question. Which of the following immunologic abnormality is most strongly associated with chronic disease? So, chronic Whipple's disease. So, what are the immunological abnormality we have seen till now? Immunological abnormality is decrease in Th1 response, increase in Treg, impaired cell-mediated immunity, which led to defective phagolysosome formation. Okay. So, which one is correct answer here? Among them, option C is the correct answer. Okay. All right. Now, let's discuss pathology a little bit more. So, hallmark is pass positive forming macrophages. Intestinal changes are villus atrophy, lymphangiectasia, crypt hyperplasia, and epithelial apoptosis. Obviously, this can be seen in histopathology only in microscopic appearance. Grossly endoscopically, we get thickened granular mucosa. So, as you can see here, this endoscopic image. So, you can find there are a lot of white spot available, lot of white spot here. These are thickened granular mucosa. Why does it happen? It happens because lacteals in the intestine gets dilated. So there is dilated lacteals, which results into such thickening of the granular mucosa. Okay, so this is the gross appearance on endoscopy, which can be seen in case of Whipple's disease. All right. Okay. So coming to next question, if you check. So here, a researcher studying Whipple's disease notes exposure to organism is common, but chronic disease is rare. Which treatment regarding epidemiology is correct? So animal are the primary reservoir. No, it is false. Transmission occurs exclusively. This is also false. Most exposed individual develop symptomatic intestinal disease. No. You see, less than 0.01% only of exposed only develop disease. Most exposed individual are rather asymptomatic, so they do not develop the disease. Humans are the only known host. Okay, this is the true answer here. Humans are the only known host in case of Treponema Whipple. Now, coming to clinical features, you see asymptomatic carriage is most common, more than 99%. So, how can we detect asymptomatic carrier? We can detect the stool PCR or saliva PCR. Stool PCR will give 1 to 10% of positive research. And higher, it can be seen in sewage workers or tropical children. There is long carriage possible, so carrier can be for more than 10 to 20 years. And progression is very rare, already less than 0.001% develop into disease. Okay, so it is a very rare disease. Now, what are the usual presentation? Usually, these are chronic in nature until and unless there are some cases in children where acute infection may lead to gastroenteritis like manifestation. There can be febrile illness, not specific fever like symptom. There can be pneumonia like presentation, but all of these are rare. Mainly, it presents a chronic infection, and chronic infection is a multi-system pattern. This chronic infection is multi-system disease, and at first phase it mimics like rheumatological disease. How so? It mimics migratory arthritis. So it is one of the mimicker of rheumatoid arthritis. It involves the distal joints, mainly distal joints, usually the wrist, it is the lower limb distal joints like ankle like knee. So all of those distal joint involvement can be seen in case of migratory arthalgia associated with Treponema Whipple. So it mimics the distal joint involvement, and it mimics seronegative arthritis, that is RA. Sometimes duration is 6 to 8 years before GI symptom, onset of the GI symptom. So before onset of GI symptom, there is already a symptom of rheumatoid arthritis in such patient. Okay. So most important thing here you should to know. So a patient presenting with joint pain in the knee, wrist, ankle, and metacarpopharyngeal distal joints, you think that it to be RA. You have done RA factor at anti-CCP. Obviously, if it is Whipple's disease, it is going to be negative. At this point, you cannot level cross out, obviously level cross out it to be RA. You level at this point it to be seronegative RA and start treatment. What is the treatment? Treatment is usually the steroids along with HCQS. Fact is that if it is seronegative arthritis and rheumatoid arthritis, at this point, steroid will resolve the disease, will recover the disease, will help the patient in symptom. But steroid in Whipple's disease decreases immunity, and pathogenesis was only decrease in immunity, decrease in cell-mediated immunity, and decrease in Th1 response. That's why steroid will make the disease bad, will make the condition bad to the patient. So, rheumatological phase in Treponema Whipple with steroid condition worsens. Okay, so this is the important concept you need to understand here. Okay, so what are the feature? Lab RF will be negative, ANA will be negative. So it is misdiagnosed to RA, and steroid will worsen that disease. All right. So second disease pattern you should know is intestinal phase. In intestinal phase, symptom is chronic diarrhea, weight loss, abdominal pain, and fever. You see at this point, it differential becomes TB or malignancy. Why this is also important? Because in TB, sometimes on biopsy, you can get pass positive cell. So pass positive cell on biopsy, it becomes TB2. It can be TB2. And symptom is similar like TB, chronic diarrhea, weight loss, abdominal pain, and fever. So all of these are symptom of TB. At this point, if you look into the other sign like hepatosplenomegaly and ascites, these are also seen in TB as well as malignancy. And on imaging, it revealed mesenteric lymphadenopathy. So as it reveals mesenteric lymphadenopathy, so it becomes a mimicker of lymphoma as well. Okay. So for what is the next step? At this point, next step is obviously endoscopy, which will reveal pale shaggy mucosa and white spread, which is dilated lacteals. Differential diagnosis is Crohn's disease, celiac disease, and giardia. Okay. So now another important thing you should know that in Whipple's disease, if it is diagnosed Whipple's disease, there is 50% chance of CNS involvement. So very high chance of CNS involvement, and most common CNS feature is dementia. Okay, it occurs in 50%. That's why all the diagnosed case of Whipple disease, you should go for CSF examination. Why CSF examination? Because you can at that point rule out or rule in CNS involvement, and if there is CNS involvement, treatment changes. So dosage of antibiotic for Whipple's disease without CNS involvement, with CNS involvement is different. That's why it is mandatory check for CSF analysis in all diagnosed case of Whipple's disease. Now, what are the features in CNS? One is cognitive decline, which is most common. There can be personality change, hypothalamic dysfunction, and supranuclear thermalgia. Then is one highly specific sign, which is like pathognomic feature, This is known as oculomuscular myoerythema. What is it? It is mainly due to involvement of supranuclear fibers from the eye as well as masticatory muscles like masseter. So what happens? There is gaze palsy, usually the vertical gaze palsy, and eye movement. Along with there is jaw movement like myoarrhythmia due to masseter muscle involvement. This is very much highly pathognomic feature. This is rare, highly specific, and highly pathognomic for diagnosing almost invariably oculomuscular myarrhythmia means this is nothing but a Whipple's disease. Okay. So what other signs, CNS sign can be seen? Seizures, ataxia, myelopathy, limbic encephalitis, and polyneuropathy can be seen. Even MRI shows hyperintensity is in temporal midbrain hypothalamus or thalamus region. And CSF is mandatory. What will CSF reveal? CSF will reveal lymphocyte pleocytosis, increase in protein, and decrease in glucose content. Okay. So coming to the question, 60-year-old 60-year-old presents with progressive memory loss. CSF PCR detects Treponema Whipple. What is the most specific clinical sign? It is nothing but oculomuscular myarrhythmia. Now, which of the following is the most common cardiac manifestation? So, cardiac manifestation most common, remember, it is culture negative endocarditis. So, even it doesn't follow the Duke's criteria most often, so it is very hard to detect. Most common valve involvement is aortic followed by mitral valve. So these are the most common valve involvement. Complications are similar like to any other endocarditis, and even if aortic and mitral valve involvement is there, at this point surgical requirement is there. Treatment of culture negative endocarditis due to Whipple's disease is by doxycycline plus HCQS for total duration of around 18 months. Okay. All right. Now, if you see pulmonary diseases are like ILD, nodules, effusion, pulmonary effusion, lymphatic is mesenteric and retroperitoneal lymphadenopathy. So coming to this question, which is the most common cardiac manifestation? This endocarditis. Endocarditis it is culture negative endocarditis. Okay, all right. So which imaging finding is most commonly seen in abdominal CT? It is mesenteric lymphadenopathy, and it becomes mimicker of lymphoma. So let's just come into this part. So what are the other manifestation? Ocular, remember uveitis is the most common. It is also asked in MCQ. Uh, It is not corneal ulcer or any other keratitis. It is the uveitis which is the most common. It is not the glaucoma even. Uveitis is the most common ocular disease. So steroidal worsen disease. So this is one of the important fact you need to know. Dermatological manifestation, there can be hyperpigmentation, nodules and purpura. So common forms are endocarditis, CNS disease, uveitis, and arthritis can be seen in isolated infection. In relapse or iritis, fever, arthritis, skin lesion, or uveitis can be seen. So how to diagnose the case? So obviously we have checked. One of the key point in diagnostic point is that biopsy will reveal past positive macrophages which are diastase negative. These are foamy macrophages. Foamy macrophages. Okay, but issue is that past positive macrophage can be seen in other causes too. It can be seen in tuberculosis also too. So it is also not specific, also seen in mycobacteria. So what is the most important diagnostic tool? You cannot also go for culture because it takes 18 days for doubling time. So it is very difficult to culture within this stipulated time period. It may take months to culture. So specific is PCR. It has high sensitivity and specificity. And PCR for the tissue has more importance than the body fluid. Remember, duodenal, CSF, bulb tissue, and urine can be used, but stool or saliva are not used usually for PCR diagnosing. These are used mainly for checking for carriers, asymptomatic carrier, stool and saliva. Okay, so among them, obviously the tissue one, duodenal biopsy and bulb tissue biopsy are better choice. Okay, so here remember, if cycling threshold is less than 30, it's supposed diagnosis. What does it mean? So while doing PCR, we go for cycling. We go for cycling of the sample to get multiple cycle and check whether PCR can analysis or find or not. Now, if this cycle is less than 30, it means within less than cycling there is growth or there is detection of Treponema Whipples. So if it's detected at very low cycle, it means bacterial load would high, so there is high chance of infectivity. Suppose it gets detected after say 40 cycle or 50 cycle. What does it mean? It means bacterial load is low, so they can be as asymptomatic carrier. They can be asymptomatic carrier. All right. Okay. So cycling time less than 30 along with tissue biopsy positivity suggest the diagnosis of Whipple's disease. So which of the following is the most sensitive and specific diagnostic test? Pastoring biopsy? No, it is not. Maximum you have done Mesty care at this point. So pastoring of biopsy is not the diagnostic test. It is rather the PCR, which is the diagnostic test, which is the best and most specific test for diagnosing the case. Okay. All right. Now, what not to rely? Obviously, stool PCR, saliva PCR, because it is used for detecting colonizer earlier. CSF examination should be done in all cases. In all cases of CNS involvement is common and it guides the treatment duration. Other tool, obviously, immunohistochemistry versus pass. Fish can be done, electron microscopy can be done, imaging like FDG PET is also can be done because it helps to detect the lymphadenopathy. mainly the mesenteric lymphadenopathy, and particular site from where we need to go for biopsy. Okay, culture is possible but impractical because it require lot of month for going for culture. Now coming to the next question, which of the following sample is not appropriate as sole diagnostic test? Yes, stool PCR is not appropriate for the sole diagnostic test. Tissue one like duodenal or valve tissue are the best. Okay, CSF is mandatory because in 50% of cases, 50% cases CSF becomes positive. Okay, all right. Now coming to the next question. So this is a tricky question. Most of you, I mean, all of you have marked it is wrong. So treatment is that general principle is that we need rapid clinical response. Look, this patient who is diagnosed as Whipple disease, so you have made the diagnosis of Whipple disease, they are carrier, maybe carrier for prolonged period, 8 to 10 years. They can be misdiagnosed as a rheumatoid arthritis for 5 to 6 years long until and unless they show any kind of intestinal manifestation or other organ manifestation. So until and unless someone thinks about it in such lines, there is no biopsy, no specific test has been done, we cannot detect Treponema Whipple or Whipple's disease. So patient was diseased for prolonged period. So you need rapid clinical response and require prolonged therapy to eradicate the disease from this patient. And issue with this is that there is high relapse rate. So treatment often may continue lifelong to prevent relapse. Okay. So what is the standard regimen? Standard regimen is induced with IV ceftriaxone or IV meropenem. So dose is 2 gram BD for ceftriaxone and 2 gram TDS for thiazide for meropenem. Now it is an induction therapy. Maintenance is doxycycline plus hydroxychloroquine. Alternatively, minocycline can be chosen. Now, why hydroxychloroquine? Hydroxychloroquine because it raises the phagosome pH and enhance antibiotic action. So that's why hydroxychloroquine is used. Now, regarding TMP and SMX, there is trimethoprim and sulfamethoxazole. So it works only when there is dihydrofolate reductase in bacteria. Treponema hopefully lacks dihydrofolate reductase enzyme. Therefore, they are intrinsically resistant to these two drugs, trimethoprim and sulfamethoxazole. That's why that is not useful, and sulfa resistance is possible and relapse is common with use of this drug. Okay, so why is TMP SMX monotherapy no longer considered reliable for treatment of Whipple disease? It is because of its lack of activity of trimethoprim, because of absence of dihydrofolate reductase, So P is the right answer. All of you had marked wrong here in this part of the pore sinus penetration answer. Okay. Now, special situation, remember in CNS disease, high dose IV therapy is mandatory. That's why to rule out CNS disease is mandatory in such cases. In endocarditis, it is doxycycline plus hydroxychloroquine for more than 18 months and surgery if severe disease. Monitoring is by PCR, either CSF or urine. Urine is the newer tool that is being ongoing. Persistent positivity, what should be your approach? You should be is to, if because this is a prolonged disease, it can be positive for 1 year, 2 year, or 3 year. You need to continue the medication, or you can consider to change therapy also and look for. There can be complication like Jerry-Hersheimer reaction with any of the antibiotic too, and obviously iris. And in iris, what to do? You treat the steroid versus thalidomide. Long-term strategy is that lifelong doxycycline suppression. Okay. All right. So if we check into the next question, which of the following is recommended as long-term management strategy to prevent relapse? It is lifelong suppressive doxycycline because relapse is very common. Relapse is very common. So you need to lifelong suppress with doxycycline. Okay, this is the answer. No, short-term therapy followed by oral only for 6 months is not preferred in for Whipple's disease. So prevention is no standard prevention is available. Vaccination is under research. Okay, so that's all regarding Whipple's disease and MCQ regarding to it this chapter. So those who want to join this Harrison based group discussion, link is in below. You can obviously join this discussion. Thank you.